Hello everybody, this is Dr. Carlo Oger, board certified emergency physician with DrER.tv. If you're watching this video, you are actually at ED Video Pro channel, which is a channel specific for the medical healthcare enthusiast, whether it be a student still, a nurse, a paramedic, or anybody who just wants to learn about medicine in general. And we're doing clinical cases and posting them almost daily, so stay tuned to this channel for more cases. This is a 47-year-old woman who presented to the emergency department with a rash that developed on her thighs, knees, and left buttock during the previous day prior to the presentation. There was significant pain throughout the affected area. She presented one day after discharge from the medical intensive care unit for hypertensive emergency, where she was diagnosed with bilateral lower extremity deep vein thrombosis. She began receiving intravenous heparin, which is a blood thinner, and she received initial dose of warfarin, Coumadin, at 10 milligrams. 2 days later, warfarin was decreased to 7.5, and she was discharged 4 days after initiation of therapy with an INR, international normalized ratio, of 4.6. Normally, our target is somewhere around 2.5 to 3. So this was a little bit too thin on her blood sample. On presentation to the ED, her international normalized ratio was actually 6.9, which is definitely way above of where you want this patient to be. So she presented to the emergency department with hypertensive emergency. Let's not forget that. She was admitted for treatment and then ultimately diagnosed with a lower extremity DVT, which required intravenous heparin, which is a blood thinner, to treat those clots. Heparin can only be given IV, so she was switched over to warfarin. And as the INR started getting higher, the blood was thinner, then she was able to be discontinued for the heparin and be discharged on Coumadin or warfarin alone. Now this is what the rash looks like. You can see it's both thighs, extremely purpuric, a deep red color. It looks like the whole leg is swollen and tight. It obviously looks extremely painful. And look what her knee looks like. I mean, that just looks like blood laying on the soft tissue, maybe an effusion, or actually like basically a clot of blood in the subcutaneous tissue of this patient. That does not look good at all. So what is the diagnosis? This is actually warfarin-induced skin necrosis. Skin death. Necro means death. So warfarin-induced skin death. It occurs very, very rarely, 0.01% to 0.1% of patients who begin receiving warfarin therapy. That means if it's 1% is 1 in 100, if it's 0.1 is 1 in 1,000 patients. That's still pretty considerable because we send a lot of people home on warfarin. So it still could be a number of people who have warfarin-induced skin necrosis. So it's not so rare for the medical professional, but very rare for people out there in the community seeing these kind of cases. In 93% of the cases, symptoms begin 3 to 6 days after the initiation of therapy, but cases have been reported as late as 18 months. So it's not really an allergic reaction, it's just a reaction that can happen anywhere between 3 to 6 days, but up to a year and a half after starting therapy. Diagnosis is made clinically. That means you just have to see it once and then you're like, that's what it is. He has a rash, usually appearing over fatty area, most commonly over the breast, followed by thighs and buttocks, like it was in this patient. It is more common in middle-aged perimenopausal women with venous thromboembolism. That means DVTs, but also other clots. 75% of patients with warfarin-induced skin necrosis who begin receiving treatment for DVT or pulmonary embolism may have a baseline depletion of protein C and protein S, an activity caused by consumption by the thrombotic process. So because they have a DVT, they start depleting the protein C and S, and that leads to this problem. Pathophysiology may also involve large loading doses of warfarin, thrombosis of superficial dermal capillaries, and inherited protein C and S deficiency. So not only people who acquire a deficiency of protein C and S, but people who already have it genetically. Treatment entails discontinuation of warfarin and probably avoiding it forever, and replenishing vitamin K dependent factors. So we give vitamin K that can be given orally or can be given IV. Ideally, PO is better. It circulates right into the venous system from the absorption in the GI tract, and it causes less anaphylactoid reactions. Also accompanied by debridement, you actually have to open up these wounds, remove the clots, and then grafting because of the skin dies. It's necrosis, right? So you have to do grafting and sometimes amputation as needed for the skin necrosis. So if it's bad enough, they end up losing limb. Heparin should be used for long-term treatment of thromboembolic disease. That means these patients can no longer be put on Coumadin in the future, and you might have to use other alternatives like heparin. Now, nowadays, we have other drugs like Pradaxa and Xarelto and Eliquis. So maybe we can treat those patients with those medications and not have to use heparin either. But what do we need to learn? What are we going to take out of this case? You ever see something like that? Always think of, especially if they were on blood thinners, of Coumadin-induced reaction. Check their INR. If it's very high, obviously the anticoagulation needs to be reversed because they're actively bleeding in their thigh. Their hemoglobin might have gone down, so they might need a blood transfusion that will replace some of those coagulating factors. It can be seen, and first, it's rare, but it happens. It can be seen anywhere very early after starting therapy, 3 to 6 days, but it can be seen even a year after starting therapy. Also, it's because there's a deficiency of protein C and S, whether acquired or something born with, and the treatment involves replenishing vitamin K dependent factors, and of course surgery, grafting, and sometimes amputation. So very serious condition. Hopefully you'll remember these pictures and you'll be more likely to make this diagnosis. I hope you're learning with these videos. I hope you took some take-home points to memorize and learn so that you too can be a better medical provider, a more astute clinician to help in making diagnosis and treating patients early and well. We'll see you in our next video. Bye-bye.